Well, good afternoon, and it's a very awake audience after the lunch. I'll be talking about uveitis, which drives a viral ocular hypertension to an advanced glaucoma. It's a case, and will be taking up the implications of the case. So this 32-year-old gentleman complained of pain in his left eye since 3 months, gave a history of dull headache with occasional pain and mild photophobia. He was operated for a traumatic cataract in the same eye 15 years back and had a left eye laser iridotomy a month back elsewhere, and there were no records available with the patient. The best corrected visual acuity in both the eyes was 6.6 when he presented to us. The left eye had a pressure of 28 and both the eyes were on 4 topicals with an oral carbonic anhydrase inhibitor. The right eye was unremarkable. The left eye showed an AC reaction of 1+. There was no flare. There was patent iridotomy. There was no patchy stromal atrophy or any peripheral anti-acynic. The patient was pseudophakic, as I mentioned, and we noted that the patient had diminished corneal sensation. The optic nerve head was quite healthy at presentation. The gonioscopy showed open angles with some patchy pigmentation in the inferior angle. The OCT retinal nerve fiber layer in macular GCC was essentially unremarkable in both the eyes. The perimetry also pretty much looked grossly normal. So keeping all this in mind, I thought of inflammatory ocular hypertension, the criteria of which befitted our patient, and the common causes of inflammatory ocular hypertension were herpetic anterior uveitis, or we could suspect a Posner-Schlossman syndrome. The CMV infection was not much on the top of the list in my mind. I revised the therapy. I took off travoprost from the patient's original regime since it is a pro-inflammatory drug and the patient had quite a bit of inflammation already. And we started the patient on topical steroids along with the cycloplegics in the left eye. Since the patient had reduced corneal sensation, we sent a torch test sample. It came out heavily positive for IgG rubella and IgG CMV. The patient was HHH negative and TPHA was also negative in this patient. So we revisited our diagnosis and we thought of CMV anterior uveitis with a glaucomatocyclitic crisis in this patient. So with the literature, we started the patient on valcyclovir 500 milligram TID, and topical ganciclovir gel was also started for this patient. The IOP profile on subsequent visits over a month were in early teens in the right eye and mid to late 20s in the left eye. The patient was lost to follow for 3 months and reduced their anti-glaucoma medication on their own. And then they came to us one fine day in the emergency with a pressure of 58 and the vision dropped to 4/60 in the left eye. The anterior chamber cells were present and there was massive vitritis and the cupping had now increased to 0.5. There was a decline in structure. And we planned this patient for an augmented trabeculectomy. When I did the HHH testing again, he was HCV positive. There was a chronic hepatitis which was detected and AC tap was sent for PCR. Although the PCR results were negative, we went ahead with the trabeculectomy. All seemed okay in the trabeculectomy. The bleb was quite functional. And on day 8, I was met with the shock and a surprise of my life that this patient had a massive vasculitis with vitritis. There were several retinochoroidal folds with superficial retinal hemorrhages. And FA confirmed our findings. The patient was having some changes of hypotony, maculopathy with mild vasculitic changes on FA. There was a recurrence of viral uveitis post-TRAB. So we stepped up on the oral steroids. We stepped up on the valcyclovir from 500 to 1 gram TID, and we advised the patient not to discontinue the medication now. And this had to be continued for at least a year. Day 14 was good because we saw that hypotony had almost resolved and there was no more vascular sheathing that we had seen on day 8. There were no more ILM folds. So going by the Titan study and the protocol that they have given for the CMV anterior uveitis, it's always a good idea if the patient shows recurrence of anterior uveitis with inflammatory ocular hypertension to keep the patient on long-term valcyclovir treatment along with oral steroids and with topical ganciclovir to take care of the pressures. The Titan part 1 talks about the herpes simplex uveitis. And so the key message I would like to convey is to steroids must be tapered very slowly in such patients, and oral antivirals must be continued for at least a year. And there are no standard guidelines as regards topical or oral antivirals, but chronic inflammation, multiple mechanisms, systemic associations, and unpredictable response to treatment may make such challenging cases very, very difficult. So patients must be told about the long-term need for therapy. Otherwise, recurrences and a faster progression of the disease is inevitable. Thank you very much.